This is this patient's frontal x-ray. You can notice that the mastoid processes of her temporal bone are not equally aligned. This one on the right side is caved in and closer to the midline than is the left. These temporal bones contain the glenoid fossas, so you can see that the glenoid fossas are not lined up symmetrically either. This is the probable reason why the disc on the right is picked up as being displaced by the MRI. You can also see that she has a deviated nasal septum right up here. Evaluate the nose for whether it's obstructed with overgrown turbinates or it has a nasal airway present. This is this patient's submental vertex x-ray. You can see that the mandible is not centered in the base of the skull, but is off to her left side. You can see the space between the right side of the mandible, which is right here, and the right side of her head, which is right here. And you can see that it is inset quite a distance, whereas on the other side, it almost is superimposed on the outside of her head. Also, you can see that this side of her head is more normally rounded than is this side, which has been flattened. All of these are cranial compensations to the displaced disc. This is this patient's Panorex x-ray. You can see that she is missing 4 third molars as well as 4 first bicuspids. This is in keeping with her history of having had 3 years of orthodontic treatment. This is the patient's lateral head x-ray. You can see she has a fairly substantial airway right in this area. This black shadow is her airway. You can see that she is suffering from suboccipital decompression of the tissues here at the base of the skull. There should be a 14 millimeter gap between the base of the skull and the first cervical vertebrae. This patient was diagnosed with dystonia and myoclonus. She's had migraines with aura all of her life, occurring all day long. She's had tension headaches up the back of her neck and head. Her whole body tremors and twitches. She's got bilateral arm numbness, left arm worse than the right, throat constriction, history of otalgia as a child. She's on medical disability leave since 2007. She also complains of headache with left face pain, photophobia, bilateral tinnitus. She complains of bilateral preauricular pain, left side worse than the right, bilateral arm numbness, left side worse than the right, bilateral TMJ crepitus, right side worse than the left. Her mouth locks shut, inability to move her mandible to the right, painful to chew food, difficulty swallowing, bilateral suboccipital pain, neck and shoulder pain. Her previous treatment consists of seeing 5 orthopedists or neurologists for back pain. She's had microdiscectomy and laminectomy. She's had chronic pain management, multiple nerve blocks and facet joint blocks. She's been to see 2 different headache specialists. She's had acupuncture and biofeedback. She's been to see a movement disorder specialist and multiple physical therapists, which she describes as 6 to 7. The medications she's on are Flexeril, atenolol, clonazepam, Scalaxin, Percocet, Maxalt, Seasonally, Zoloft, Dionex, and Lodine. These are tomographs through the patient's right temporomandibular joint in centric occlusion. You can see where the condyle is located posteriorly in the fossa. It should be at least centered in the fossa or slightly anterior of center in the fossa. This is initial tooth contact, showing the position of the condyle in the fossa, and this is bite tight. You can see that the posterior joint space, or the behind the condyle, is diminished from the initial tooth contact to the clenched position. This means this patient has a distal skid from initial contact to bite tight. There is not supposed to be any distal skid. There should be no change in these two images in either the left or the right temporomandibular joint. So we can tell just by looking at the images that her occlusion is not correct. This is the patient's submental vertex X-ray, and you can see the mandible is not centered in the base of her skull. In fact, it appears a little bit cocked to one side. We take this view with the mouth wide open so we can image the first and second and sometimes the third cervical vertebrae of the patient. You can see that the lateral process of C1 lines up with the lingual cusp of the teeth in the upper arch on the right side, and on the left side it lines up with the buccal surfaces of the teeth, meaning the skull is either displaced to the patient's right or the cervical spine column is displaced to the patient's left. You can see that the foramina through which the nerves go are not aligned properly. You can see that this mastoid process on the patient's right side is much higher than on the left side. This is the initial appointment of a patient who comes to me with gait problems, meaning walking disabilities, and all the typical symptoms of a Tourette's patient. She also has the symptoms of a TMJ patient. You can see in this video she is using a cane. She also described to me that she uses a walker also when her condition worsens. You can see the MRIs of her on the view box in the background. We never, ever initiate treatment without MRIs on these patients. This is the very next day. What we wish to accomplish on this is a diagnostic workup, which means a bunch of very sophisticated tomographic x-rays through the temporomandibular joints, impressions, and possibly her splint delivery. She comes with all kinds of head movements, hand movements, foot movements, and pain. Notice the uncontrolled movements of her hands, feet, and head.
She's holding her head up. That's what he's saying.
Okay.
Tell us what your symptoms are so we can record them.
I feel really, really tense all through here, and I can't stop twitching, and my eyes blink like crazy. And it shakes, like the back of my skull almost like shakes.
And how long has this been going on?
Long time.
Years?
Well, I didn't shake like this. I just didn't have until I started screwing around with my mouth TMJ stuff, but I didn't have any motion in my neck, and I would get horrible neck pain and stuckness, like torticollis thing, and migraines. And now those are getting better, but like I twitch a lot. If I'm not somehow supported, so I like put pillows under my arms and under my head and stuff, but raising my mouth seems to help stop twitching. I still get twitching sometimes, but not like this bad when I have something in my mouth. And opening it wide hurt.
Constant eye blinking and head twitching are cardinal signs of Tourette's syndrome. Pain upon opening or limited opening of the mouth are cardinal signs of internal derangement of the temporomandibular joint. Many times these patients will present with symptoms of both Tourette's and TMJ internal derangement. I have had the patient using tongue blades in her mouth to determine what the vertical dimension is, so that I know at what vertical dimension to construct the lower splint. At this point in time, I am delivering the lower splint for the first time. Okay. Will I see you?
Yeah, there's one like there's a high dot right over here, but otherwise it should be good. Much better like the left and the right side seem.
You like that, huh?
Yeah.
Okay.
Sorry. In here sometimes looks like it gets a little like
As I take the appliance in and out of her mouth, adjusting it each time, notice that when I insert the appliance, her head and facial movements and blinking greatly diminish. And then when I take it out for the adjustment, they return. And then when I put it back in the next time, they greatly diminish. You breathing better? Okay. Let's see you get up and walk. You think you can walk?
okay. But I wasn't walking especially normal when I came in, just, you know.
Yeah, I didn't see you come in, but were you walking when you came in?
She was walking a little bit funny. Like this.
Okay. Okay, turn around and is that any better at all than when you came in or not?
I think it's a little bit better. I still feel it here, but I'm not. Well, it hurts just as much. I'm not quite as wobbly, I don't think.
Walk back over there. Many of these patients also suffer from low back or sacroiliac pain. This is due to sustained muscle contraction in this area. The patients invariably experience relief of these pains due to these appliances we make. We judge the effectiveness of the appliances by how they walk initially. Any improvement of the walk occurs in the first 2 or 3 minutes and then continues thereafter. And it gives us an idea of whether we're on the right track in the treatment of these patients. Believe it or not, this is an improvement in her walking. If you did not discern any noticeable difference, notice how her walking completely degenerates when I take the appliance out of her mouth. It's not as good, is it?
I feel shakier.
Okay, I'm going to add to this. I have increased the vertical dimension 3 times, in fact, on this patient. You seem to get out of the chair a lot easier. Okay, turn around. Okay. Okay, let's leave it like this for today, and this should improve. Practice walking backwards at home, not particularly here. Do that like 5 or 10 or 20 times a day, 10 feet across your living room or something. And people seem to adapt to it, improve quicker with practicing walking backwards.
Okay.
And
Okay, this is the next day. Go ahead and tell us how you're feeling.
I'm feeling really well. Yesterday I went home and just napped for a little bit. And when I got up, I could walk much better, more steady, and my low back pain was mostly gone. And I could do a little bit, like just leaning that little bit forward and back that normally kinks me up. I could do that, which was really good. And this morning I'm walking really well and sturdy. and my neck has calmed down. So, and I can actually like look up and down, which normally, makes me twitch a lot. So.
And no spasming.
No, if I take this out, it will spasm. But this is pretty good for me to be able to lift my head up that far.
Okay.
And I don't have any. I'm walking pretty evenly.
Okay.
So really good.
Good. Let's see. So your hands aren't shaking anymore.
Nope.
Your feet.
Nope. I can hold my head up by itself.
Okay, go ahead.
Keep in mind that these results were obtained within 24 hours of her initial appointment without the use of medications or psychological therapy to suppress her symptoms. We are trying to treat the prime cause of her symptoms, which will be revealed to you as we go through this DVD. Okay. Her opening has increased to 46 millimeters. Yesterday it was 41 millimeters. That's a 10% improvement, just like that. We're going to do a final adjustment and then send this young lady back to Cleveland. Jump shot. Okay. This is the final splint configuration. Okay.
Wonderful.
6 or 8 weeks, sweetie.
Yep, we got 6 weeks planned.
Okay.
Already in the book.
Good.
Thanks, you guys.
Bye.
Remember her initial appointment when you saw the MRIs hanging on the view box? These are MRIs through the left and right temporomandibular joints in both the closed and the open positions. The big question is, what did they reveal? Because you recall I told you that most of these patients were both Tourette's and internally deranged TM joint patients. And although we have addressed the Tourette's symptoms, it is not sufficient, in my mind, to do just symptomatic treatment. You have to address the prime cause of all the symptoms. It is now time to address the TMJ symptomology. The MRIs reveal that the discs within each joint were anteriorly dislocated without reduction. That means they were displaced to the front and did not go back into place upon opening of the mouth. This is why it hurt her to open and why her interincisal opening was limited. Although you may think 46 millimeters was a normal opening, to me it is an impairment of function. The normal opening should be 50 to 54 millimeters, in spite of what you may have been told by other people. So therefore, we now address the internal derangement, and we do this by open joint plication surgery. It has been my experience over the past 45 years that if you address only the symptoms without the TMJ dislocation, the treatment will have no stability and the symptoms will return within 1 to 3 months. Therefore, to provide long-term stability in the treatment of these cases, we must get the left and right displaced TMJ discs into their normal anatomical position in such a way that they stay there. And we do this through left and right open joint TMJ plication surgery. Those of you who are healthcare providers should know that it takes a very courageous patient to proceed with this step of TM joint surgery, because they have experienced such an improvement in their symptoms that they are afraid that they will risk losing this improvement if they go on to this additional treatment. To me, this is an irrational fear. It will only improve them if the surgery is done correctly. This is the patient 3 days post-surgically. She had a left and right open joint plication procedure. I've reviewed with the patient what her presenting symptomology was, and she's going to tell you the improvement.
I feel great. I'm surprised at how great I feel I can move without tremoring, and my back and my neck are not hurting. I can do the opening of my mouth without tremoring. When Dr. Stack was just measuring me and I, taking my appliance in and out, my head wasn't shaking, my arms weren't quivering, and I'm not in pain. I've been in pain for a very long time, so I don't even know how to explain it. It's really wonderful. Do you want specific?
You had trouble walking, right?
I had a lot of trouble walking.
Okay, why don't you get up and walk out there and then back, and we'll just...
I can get up and down without using a cane or a walker, and I can walk
Okay, see that?
with a regular stride. I don't feel like my thighs are pulling on my back anymore, and I feel like and my neck isn't sore just like all the time. Usually it's hard for me to just hold my head up.
Okay, do it one more time up to that. Right at the back.
What's the difference likely to be when she's off medication?
Even better. Even better.
Can you believe much better? Except my chair's
Okay.
yeah.
Okay, we are rebalancing the patient's surgical splint to compensate for any spasm, muscle spasm, swelling, etc. And then we'll dismiss the patient and see her in the near future.
Right after surgery, I have been just amazingly better. I had, for the last 10 years, I've had pain, constant pain in my back, in my neck. I've had debilitating migraines. I have walked bent over funny. I tremored. My tremors got so bad that I couldn't stand right. I was using a cane. Sometimes I've been sleeping on and using a massage table. I haven't sat on a couch in like 10 years. I have been through every physical therapy, back surgery, steroid shots, pain blocks, everything, and nothing has worked. And the surgery, since I woke up from surgery, I could stand up, right up. I always used to have to push myself up with my arms, and I would be shaking. I couldn't look up in the air or to the side with my head, and I would blink like crazy, and my head would twitch to the left, and my husband would have to carry me around and get me up and down the stairs, or I couldn't go. I was homebound a lot. I couldn't drive a lot. I had trouble attending things, like just having trouble, going to my family's weddings and things. So I was very non-functional. And since the surgery, I can walk. It's not pulling on my back. I don't have constant back pain. I don't have constant neck pain. I stride normally. I have had no tremors at all. None in my hands, none when I'm moving, so I can look up all the way, and that would normally make my whole body tremor, and I can look to the side, and I can stand and sit without having any trouble with my back, without using my arms to hoist me. And I'm walking upright, so I'm going to be able to get stronger, because a lot of my muscles didn't work the right way. For so many years of compensating. So now I'm just working on strengthening and getting the proper muscles to work. But it's truly amazing. My family, my doctors can't believe it. They're so excited, and I feel happy. And they say I'm like I used to be. My face and my movement, and it's just so nice not to have constant pain all the time and feel like I can't even get around my own house. So I don't need a walker. I've used a wheelchair, and I haven't used that or my cane or anything since surgery.
And if I think Dad, he hasn't had to carry me anywhere. So it's been wonderful. I'm really just excited to keep getting better.
After treating her with great symptomatic improvement, we recommended that she have bilateral TM joint surgery. The left TMJ disc was displaced with 40% of the disc anterior to the articular eminence. The disc was abnormally thin. The surgeon placed the disc in its normal anatomical position and sutured it in place. The right disc was displaced with 20% of the disc anterior to the articular eminence. The right disc was also significantly medially displaced, but in good condition. The disc was placed in its normal anatomical position and sutured in place.